What a wonderful evening. Academically, I'm super excited to moderate today's webinar. This is Dr. Vijay Kumar Chennamchetty, Senior Pulmonologist with Apollo Group of Hospitals. Today we are having a wonderful topic, most complex topic, and very much, to be honest to say, even for the senior pulmonologists, even with experienced pulmonologists, there is a lot of, clinical dilemmas that do come across with this topic. So the topic is nothing but, you all know, rheumatoid arthritis and interstitial lung disease. We are going to cover in next couple of hours A to Z about this topic. I am super excited because we have a wonderful panel, and without wasting much time, I would first of all thanks a million for the ICS to do this relentless back-to-back webinars, power-packed webinars with A to Z about every topic they pick. The main credit goes to our Dr. Amita Nene from Mumbai. She's the chair of this educational initiative, and she's a dynamic force in the medical pulmonary education across the subcontinents, which is translating and it is very impactful, across the globe without any doubts. Recently, ma'am was elected as one of the powerful women, bold lady, and she's being projected in the international IAB forum as well, World Bronchology forums as well. And she's been instrumental in fostering the academic rigor and creating platforms that encourage meaningful scientific discourse. Her relentless spirit of knowledge dissemination ensures that evidence-based medicine remains at the forefront of our discussions. Thank you, Dr. Amita, for such a brilliant initiative of ILD webinar series, and you are spearheading this academic discussions. And at the helm of the initiative, under the guidance of Dr. Samaria Sir, our esteemed president of Indian Chest Society. Sir is a truly luminary in the field of pulmonary medicine. His leadership has not only shaped the direction of our society, but also inspired generations of clinicians to strive for excellence in patient care and also in the research. Sir's vision for advancing respiratory medicine continues to set new benchmarks in this part of the country and also across global forums. And our beloved by Dr. Rajadhar, we call the king of pulmonary medicine in India. We can't thank enough by for this, academic webinar series. Thank you so much. Sir is Secretary of Indian Chest Society. Sir's passion for pulmonary medicine and clinical research is truly commendable. He is a thought leader in his own right. He has played a very pivotal role in shaping guidelines and advocating best practices and bringing together experts from diverse backgrounds to tackle pressing challenges in our field. So without much wasting the time, this evening we are going to discuss about rheumatoid arthritis, interstitial lung disease. It's a challenging topic, as I said before. We aim to bridge the gaps between the pulmonology and then rheumatology, focusing on real-world experiences, latest advances, the clinical, the drugs which are available today. They are slightly complex. We need to understand in depth of their action and their impact and also their side effects. So ultimately our goal, ICS goal, is nothing but to ensure that the right treatment goes to the right patient at right point of time. And I welcome, can you please change the slide? I welcome our beloved Dr. Nitesh Gupta, who is a good friend of mine. He is currently associate professor from Department of Pulmonology, Critical Care and Sleep Medicine at Safdarjung Hospital, New Delhi. Dr. Nitesh's interest is COPD, interstitial lung disease, systemic reviews and meta-analysis, systematic reviews and then meta-analysis. Dr. Nitesh is a true pioneer in this area and who we are excited to listen to his talk for next 20 to 25 minutes. Then we'll do panel discussion and I'll introduce the panelists after Dr. Nitesh Gupta's talk. Meanwhile, my dear friends, please ensure to shoot your questions. Don't hesitate to ask. This may be a silly question, this may be a difficult question. Do not hesitate. We have a wonderful panel to clarify all your doubts. The silly question of yours may be running in hundreds of pulmonologists. Your doubt is going to clarify their doubts as well. So, over to Dr. Nitesh Gupta for the talk of bird's eye view or drone's view of RA-ILD.
So is the slide set visible?
Yes. Yes. You are loud and clear as well, Dr. Nitesh.
Thank you. So at the onset, I would like to thank Dr. Vijay sir for the kind introduction and thanks to Indian Chess Society for providing me an opportunity to review the topic for myself first and then for the audience. So 5 years back, I had taken the last talk on ILD. Lot has changed since then. We'll be covering the same in over next 20-25 minutes. So objective of the talk is recognizing ILD is a very important comorbidity in rheumatoid arthritis. How do we work up patient of respiratory symptoms in patients with RA? And what should be the general treatment approach? So as we all know, now we don't call them as connective tissue disease. We call them as systemic autoimmune rheumatic disease, which has 6 broad categories. Rheumatoid arthritis is one of those broad categories. The categories is based on the classification criteria. If the classification criteria is met for one disease, we label it the same. However, there's still one category where we call it as a pneumonia, interstitial pneumonia with autoimmune features, which practically where we are not able to meet all the criteria of any disease and some criteria of some disease. So we label it as a basket IPAF. So pulmonary disease, the issue is when you have autoimmune disease, you can have involvement of everything. You can have involvement of airways, which can be both upper and lower airways, which can be involvement of alveoli, can be involvement of the vascular system, can be involvement of pleura. The point is all of them will lead to your dyspnea with which your patient has presented. There is a paper about 12 years back where nothing has changed since then in this category, where they have defined the disease and the types of lung involvement seen in that autoimmune disease. So when we go for ILDs in systemic autoimmune rheumatoid diseases, so rheumatoid arthritis pooled prevalence was about 0.1, which is lower than seen in systemic sclerosis, lower than inflammatory myositis, lower than mixed connective tissue disease and equivalent to SL. When we talk about rheumatoid arthritis ILD, we have UIP pattern, NSIP pattern, OIP, organizing pneumonia, LIP and others. So 4 most common are UIP, NSIP, organizing pneumonia and lymphoid interstitial pneumonias. So when we talk about the lung in systemic, when we talk about the lung in rheumatoid arthritis, as we have seen, it is a destructive, systemic and inflammatory disorder. So it involves a lot of things. Extra-articular manifestation that is beyond joints is seen in 40% of the patients. Among them, pulmonary involvement will be there in any of these forms, about 60 to 80%. So within 5 years of diagnosis, we expect the patient will have one or the other pulmonary involvement. In about minority of 10 to 20% of the patient, the symptoms may appear before the joints have happened. ILD, most common ones is UIP, NSIP, OP, LIP and others. If we talk about presentation of clinically evident ILD in patients is about 10%. But if we screen everyone in rheumatoid arthritis, even without symptoms, or if we just see the HRCT, they may be about 30% prevalence. It's a male predominant when the lungs are involved in the RA patients. So as we can see here, we have parenchymal disease, we have airway disease, we have pleural disease. We have the pictorial representation of the same. So upper airway disease, patient may present with rheumatoid nodules of the vocal cord. Tracheoarytenoid arthritis can present with stridor. Again, lower airway disease will be in the form of bronchiolitis, bronchiectasis, pulmonary hypertension, parenchymal disease in the form of ILD, pleural disease, pleural effusion, nodules. You have Kaplan syndrome as comorbidity in Kohl-Walker disease. Amyloidosis may be there. And one special category about rheumatoid arthritis is about the drugs toxicity. We'll be seeing that in later. Why is detecting ILD important? Because it increases the chance of mortality about 2.5 times in a patient of rheumatoid arthritis. So should we screen and monitor for ILD in asymptomatic patients? The query comes, whom to screen? So if we see for RA, specifically the guidelines have said, if you have male sex with older age of RA onset or longer duration of RA, you should screen. If patient has a disease activity score of 28 or has a smoking history, you should screen, and serological markers are positive. Now the question comes, when you have an established rheumatoid arthritis, how do you evaluate the ILD in such a case? So we need to have history, we need to have examination, we need to have physiology studying, and we need to have imaging. So why is this important? Because understanding the background rheumatoid activity, articular disease activity, and the past treatment is important because these are risk factors for other ILD. Symptoms, the dyspnea, as we have said, dyspnea in rheumatoid arthritis patient can be because of numerous causes and not just ILD. It can be because of deconditioning, because of musculoskeletal or extrathoracic manifestations, can be because of cardiac involvement, can be because of chronic disease anemia, can be because of embolism. The absence of dyspnea does not exclude the presence of ILD, as we have seen about 30% of the patients have ILD without even having symptoms. When symptoms are present, we usually found the crackles, clubbing remains uncommon. The particular disease about rheumatoid arthritis is, it is difficult to measure exercise desaturation. One, because of the joint deformity, patient is not able to walk or cover that distance. Second, the pulse oxygenation saturation in the deformed joints is difficult to measure. However, to note, if patient has very severe articular disease, it does not mean patient will have a very severe lung disease. We'll see it in upcoming slides, how this has been studied much better. Always do not forget about risk factors for general ILDs. It is not that patient is rheumatoid arthritis, he will have rheumatoid arthritis ILD. Patient may be smoking, so he may have smoking related ILDs together. Patient may be on chronic medications, which may cause ILD. Patient's occupational history is again important, which may cause ILD. And exposure history, as we are seeing in our country, that hypersensitivity pneumonitis cases, our detection has increased. So even that may be the factor. So it is not just that RA, patient has RA, so every ILD is RA ILD. He may have other ILDs because of other risk factors, and unless you remove them, your treatment is not going to help the patient. So pulmonary physiology wise, when you have interstitial lung disease, you find restrictive etiology where reduced FVC and total lung capacity are there. You have impaired gas exchange in the form of reduced diffusion capacity. If you have an arterial blood gas, you will find reduced PO2, that is hypoxia to the patient, or increased A gradient. Again, normal PFT or resting ABG do not exclude the ILD. What are HRCT patterns that we see? So UIP pattern is the most common pattern which is seen in rheumatoid ILD. It has a very high specificity, but UIP on histopathology in RA-ILD, but a lower sensitivity. So when UIP in an RA case, if you are seeing UIP on radiology, there are very high chances that it will definitely come out as UIP in histopathology. What are other types of RA-ILD? NSIP is again seen in about 40% of the cases, where you have subpleural spacing, ground glassing, small cystic changes, you have organizing pneumonia, and you have diffuse alveolar damage, which presents as acute exacerbation of rheumatoid ILD. So these are 4 most common patterns of ILD in the case of rheumatoid arthritis. So since interventional pulmonology is on the rise in the country, so should every ILD be biopsied? So the guidelines very clearly suggest when you have CTD associated ILDs or SARD ILDs, if a definite diagnosis of a CTD can be made clinically, histological subtyping of the type of ILD present is generally not useful except for one specific clinical scenario where you have to differentiate between a drug-induced ILD versus a disease-related ILD. And in those cases where only autoantibody is positive or features of IPAF are there, interstitial pneumonia auto features, lung biopsy may be required. So when you do not have any symptoms which are suggestive of CTDs, only the antibodies have come positive, you may need to do a lung biopsy to prove the histopathological type. But if your clinically patient is CTD, has clinical features, serological markers, radiology is suggestive of ILD, you do not need to do a biopsy in such cases except for specific scenario. How are we going to manage an RA-ILD? The problem with RA-ILD is there are very few randomized control trials. So if you ask me evidence why you are giving this and not drug B and why you prefer drug A, the whole management of RA is primarily experience based rather than evidence based. Not all cases require treatment. The 2 specific scenarios require treatment where they are clinically significant and progressive disease. Always work with the rheumatologist to find a coverage for both joints and lungs. It should not be that rheumatologist is targeting joints, you are targeting lungs separately, and patient is not getting benefited with either of the coverage. What are the factors we have to consider before initiating treatment? So we have to see 2 factors. One is ILD factor, another is rheumatoid arthritis factor. ILD factors are pace of disease, extent of disease severity, and pattern of ILD. Rheumatoid factors are again disease activity as assessed by DAS score, the disease severity, whether the extrathoracic disease is there or not, and patient's comorbid conditions like like diabetes, hypertension, coronary artery disease also needs to be considered. So when I say it is more of experience based rather than evidence based, so this is the latest study which has come out from the US, multiple centers of US, which is again a real world multi-site study, not an RCT, where they have let all the centers treat patient as per their experience. They had 212 patients where 92 were treated just with azathioprine because that center was more comfortable with azathioprine. 77 patients were those with mycophenolate mofetil. That's the other center was more comfortable with MMF, and the third center was more comfortable with rituximab. So what they did was the blue dot which we can see here in the slide set. This is practically the predicted trajectory of a patient based on minus 12 months or minus 2 years of PFT lung function decline. So they had calculated if we do not treat this lung function, how is the decline going to happen? In what ways it is going to fall? And if the similar thing was there in the DLCO. So they had studied both. They already had a preset equation where they could find the FVC decline and the DLCO decline. So what they did when they treated, they find the decline should have been on the blue line, but the decline did not happen. And there was significant improvement, we can say, or the significant less fall in FVC and DLCO as compared to one which should not have been there. Did they find any difference between non-UIP and UIP pattern? No. In both the patterns, everything improved. So they concluded that neither the drugs are important, neither the UIP pattern of ILD nor choice of immunosuppressive agent impacted the pulmonary function trajectory on immunosuppression. So your immunosuppression in a patient of RA-ILD is again based on your experience. So we have rituximab systematic review and meta-analysis where about 15 studies were there, but unfortunately there were no RCTs. So again, the clinical evidence generated by the systematic review and meta-analysis would be lower because there was 0 RCTs. So they had shown clinical improvement favors rituximab, and again for the DLCO again it favors rituximab slightly. When we combine rituximab with mycophenolate mofetil. This was again a clinical trial done, which was placebo based, but the pattern studied was NSIP pattern only. They did not study the UIP pattern. They just studied the NSIP pattern, and they showed that the combination worked very well. However, there was very high chances of risk of viral infections in these patients. Again, then the study was whether the RA-ILD could be done treated with perfenidone. It was a trial 1 trial, which was phase 2 study. Again, it did not prevent the decline of FVC, and hence the trial was terminated early because of slow recruitment. So I would like to all of you to focus. This is a very busy slide, so I would like you to focus on one aspect at a time. So for rheumatoid arthritis, ILD, you need a multidisciplinary discussion. Right now, for any ILD, you need a multidisciplinary discussion where you have a pulmonologist, a rheumatologist, a pathologist. Then you see patient has uveitis synovitis or not. You do a baseline assessment. Presence of symptoms are there or not. Whether the query is RA-ILD or whether it is a subclinical ILD. If there is patient with interstitial pneumonia, you rule out the other thing. You look for the symptoms of rheumatoid or CTDs in this patient, and then you say whether patient is RA-ILD or IPF. So if patient has subclinical ILD, please do not stop corticosteroid sparing DMARDs for RA treatment. It is not that patient is taking DMARDs which are corticosteroid sparing for RA and you find a subclinical ILD and you just stop it. There is enough evidence now that methotrexate does not cause ILD in majority or about 98-99% of the patient. So you continue to treat the rheumatoid arthritis. When you have a clinical or progressive ILD, you stop these drugs because you need to rule out a lot of other things. So what are the risk factors where RA-ILD will progress? If your pattern is UIP, if your pattern has more than 20% involvement of lung on the CT scan, your baseline FVC is less than 60%, your baseline DLCO is less than 40%, or your change in last 6 months in FVC is more than 10%, or in DLCO is more than 15%. So if you are suspecting methotrexate induced pneumonia, you stop methotrexate, give steroids and treat the patient. If your ILD is inflammatory predominant, that is your pattern is NSIP or organizing pneumonia, you give short-term high-dose glucocorticosteroids. So short-term is 3 months of glucocorticosteroids with add or switch to a biological DMARD which has a positive effect. So there are 2 biological DMARDs which have a positive effects, which are rituximab and abatacept. You add or switch to a JAK inhibitor, that is targeted synthetase DMARD, or immunosuppressive JAK inhibitors like tufectinib, or immunosuppressants like cyclophosphamide, mycophenolate, or azathioprine. Or you can switch to biological DMARD like tocilizumab, but it has a very small positive effect. When there is ILD, we do not treat with TNF alpha inhibitors. So that has dubious effect. It has shown very high risk of life-threatening infection. So the RA drug, which is not used in ILD, if somebody asks you, it is a TNF alpha inhibitor, which is not used in RA-ILD. So if fibrosis pattern is present in UIP, you start with antifibrotic agent nintedanib, and if still disease progresses, or if your progressive ILD during follow-up you see, you switch to nintedanib. It is again based on inbuilt trial where almost 50% of the patients were of rheumatoid arthritis, and that's why in progressive pulmonary fibrosis, nintedanib got the approval. Going by the European guidelines, the recent one, rheumatoid arthritis, ILD, the first line therapy is mycophenolate, azathioprine, rituximab. None is superior to the other. Any of the 3 agents can be started. If alternative you have to keep at first line, it is cyclophosphamide. So you actually have 3 important drugs, and the 4th one can also be considered with short-term glucocorticoids, which is 3 months of glucocorticosteroids, after which you stop. You continue to monitor the patients with PFT and DLCO and 6-minute walk test. 3 monthly if patient has very high risk, as we have seen in the top left corner. If any of these factors are there, you follow up 3 monthly. If none of them are there, you follow at 6 months. Again, a word about abatacept. Currently, it is not available in our country, but few observational studies, again no RCTs, have shown that it leads to stability in FVC and DLC over a period of 2 years. Once if ILD is progressive based on first line ILD therapy, you switch therapy, you either change the drugs, mycophenolate, if initially mycophenolate was there, you switch over to the other options, and nintedanib is definitely there. What is against is long-term glucocorticosteroids. So long-term glucocorticosteroids are not the treatment for ILD which is progressing on a first line therapy. Always refer for lung transplant evaluation at appropriate time for progressive disease. So it is not like if patient have CTD ILD or an RA ILD, you cannot refer a patient for lung transplant. It should be worked. We'll see in the next few slides. We are waiting results for 3 main studies: the April trial, which is abatacept versus placebo; the Palmora trial, which is tofectinib versus methotrexate; and Ritux IP trial, which is again rituximab based study for the RA-ILD. The word about lung transplant in RA-ILD: patient is to be screened early, just like we screen early for UIP. Once patient has been diagnosed UIP, you start the workup for lung transplant and start patient on therapy, as well as you take at least a referral for lung transplant. If FVC is less than 60 or DLC is less than 40 at presentation, should trigger referral consideration, or if you have now a progressive ILD despite the treatment. So summarizing the talk, when you have a patient of HRCT with interstitial abnormalities of unknown etiology, either patient has a pre-existing RA diagnosis or you looking for RA diagnosis in this patient. Once RA diagnosis is established, you look at the HRCT pattern, you discuss with the radiologist whether it is parenchymal pattern, whether it is airway pattern, or there is alternative diagnosis to it and exposure history is there. Then if there is alternative diagnosis or exposure history is there, you go for a biopsy. Again, you do an MDD where pulmonologist, radiologist, rheumatologist and pathologist are there. You label patient as RA-ILD, you would label patient as RA-associated bronchiolitis. You say RA or CTD-ILD or SARD-ILD are excluded, or you totally make an alternative diagnosis. So this is how the flowchart goes in a case of RA-ILD. So summary, MDD is the word. Don't decide alone for the treatment. Keep your rheumatologist in the loop. Keep your pulmonologist, keep your other pathologists in the loop if you have done a biopsy. Just keep people in the loop so that patient gets optimal treatment and not individual treatments. Always evaluate for dyspnea in detail. RA patient with dyspnea doesn't always mean RA-ILD. Again, be well versed with therapeutic potential of immunosuppressants, that is, which suppressants will work both for RA and the joint, whether I have to target joint disease or I have to target lung disease or I have to target both. And do not forget about the care of a chronic respiratory disease. Do not forget about vaccination. Do not forget about pulmonary rehabilitation, oxygen therapy, and if required, lung transplant. I thank everyone for their kind attention. And this is the end of my slide set. If anybody requires the slide set, they can just drop me an email. I'll be more than happy to share the slides.
Absolutely brilliant talk, Dr. Nitesh. We thoroughly enjoyed your talk, and this is a perfect drone side view of RA-ILD management. You have covered, nailed the importance of early diagnosis, and as soon as you diagnose, how to take the patient and what is the first line therapy, what is the second line therapy, which drugs you are not going to give in ILD and which drugs you should give in the ILD. And in fact, it is really an eye opener. Wonderful, wonderful listening to you. Thank you. And now, my dear friends, hope you have enjoyed the talk very well. And please share your questions. Meanwhile, we will be starting a panel here. And the panel consists of Pan-India panel. I welcome our mentor, guide, and a friend as well, Dr. P.S. Tampi sir from Mumbai. Sir, we are truly honored to have you here, and we are looking forward for your guidance in shaping this or giving a perfect shape to this webinar. I welcome Tampi sir from Mumbai. Sir is a senior consultant pulmonologist and chest physician at Bombay Hospital and Medical Research. And sir is MD DM from Chandigarh. honorary chest physician to Governor of Maharashtra, and he is a chief pulmonologist at Asian Cancer Institute and Columbia Hill Hospital, Mumbai. DNB teacher, tons and tons and tons of experience. Welcome, Tampi sir.
Thank you.
And sir, thank you, sir.
Thank you.
And my very good friend from Raipur, Dr. Devi Jyoti Dash. Welcome, Dr. Devi. Amazing academician, wonderful friend. And whenever there is an academic, she is the first one to come forward in participation. Currently, Dr. Devi Jyoti Dash is working as an associate professor at SBIMS Raipur, director Nived Chest and Eye Care Raipur. She is MD DNB, EDRM and FAPSR. Welcome, Dr. Devi Jyoti Dash. Another wonderful personality, very good friend, close to heart, and a unique combination of pulmonologists and infectious disease specialists. Wherever there is a pulmonologist and infections are involved in the academics, there is no educational event, academic event without Dr. Komal Shah. Welcome, Dr. Komal Shah from Nasik, and she is DNB Pulmonology Gold Medalist, Fellowship in ID, and John Hopkins Intensive Infectious Disease from June 2024. Currently working as an associate professor in the Department of Pulmonology, Vasantrao Pawar Medical College, Hospital and Research Center, Nasik. And working also as a consultant infectious ID specialist at Ashoka Medicover, Namco Hospital, Nashik. She has, to her credits, so she did receive Best Paper Award from NAPCON 2021, 2023, and Mahakritikan 2023, and so many. Okay, welcome, Dr. Komal Shah. Okay, we are delighted to have you here.
Thank you so much, sir.
Another good friend from Mumbai, Dr. Mihir. Welcome, Dr. Mihir. Fantastic human being, good clinician, and MBBS, MD, DNB, MD, with total conference presentations of 9, publications of 17 at a young, tender age, inspiring all others. Reviewer of JPGM, BMJ, IJS, SLVG, OMG, and SIRIS. And received multiple awards and received APSR ERS Young Investigator Award 2021, NAPCON Best E-Poster Award 2020. We are truly honored to have you here among us and looking forward for your insights in this difficult topic.
Thank you, sir.
Next slide. Ashar, next slide. Vijay, next slide, please. So, am I audible?
Yes, sir.
Yes, sir.
Yeah. Komal, can you go ahead?
Yeah, Kumar.
Sir, thank you so much, sir, for the kind introduction. And now I have the privilege of introducing our dear mentor, who will be moderating today, Dr. Vijay Kumar Chennamchetty, sir. Sir needs no introduction. Everybody in the field of pulmonology knows him. He is a senior consultant interventional pulmonologist and sleep disorder specialist from Apollo Hospital, Hyderabad. Sir has many academic qualifications. He's done MD Pulmonary Medicine, IDCCM, BPSM Pediatric Sleep, FCCP, and FSM Sleep Medicine. And Sir has special interest in intervention pulmonology with focused interest on thoracoscopy, ESLD, ILD, and ARDS. Sir is a big name, and we are very privileged to be part of the panelists along with Sir. And I'm sure that he must have set very good and difficult questions for us as well.
Thank you, Dr. Komal, for nice words. So, I was told before starting the event webinar itself, there were close to around 1,500 logins. That's an amazing, response for ICS webinars under the leadership of Dr. Amita Nene. And sir, first question to Dr. Shah sir. Sir, Tampi sir, okay, you are the senior most among us. You have seen probably for the past 3 decades that how the evaluation of RA-ILD has evolved and how the diagnostic changes have came into picture, and you would have faced a lot of difficult scenarios more than any one of us. I would love to hear from you, sir.
Yeah, at the outset, I would like to thank Dr. Amita Nene for conceptualizing this very important webinar. And I would like to thank you, Dr. Vijay, for that kind introduction as well. It's a pleasure to meet all the other panelists as well. So having said that, the link between rheumatoid arthritis and interstitial lung disease has been recognized for several decades actually. The earliest recognition was sometime in the 1950s. And when, initial reports of lung involvement in RA patients emerged. And some kind of an establishment of association of RA with ILD was made when studies demonstrated a significant association between RA-ILD, with estimates suggesting that up to 20% of rheumatoid arthritis patients may develop ILD. This was in the 1970s and 1980s. Then over the period of key findings were that various research studies highlighted the importance of HRCT chest in detecting ILD in RA patients. This was very important and was a turning point in the study of ILD in RA and TT-ILD patients, because it not only helped us to detect the ILD but also to type the kind of ILD that we had, the various discussions which Nitesh had put up very nicely, the UIP pattern, the NSIP, the LIP, the OP, and so on. So all these differences could be made on an HRCT, and we were also able to see the progress of the disease when we had the HRCT at our beck and call. In 2010 onward, studies emphasized the role of various autoantibodies, such as the anti-CCP, which we are all now familiar with in the development of RA-ILD. The current understanding, however, is that RA-ILD is recognized as a significant extra-articular manifestation of RA, with almost 50% of patients affected with the ILD part. And it is a complex interplay between genetic, environmental, and immune system factors contributing to its development.
Thank you, sir. Thank you, Tampi sir, for that crisp briefing of the challenges and then your experiences since
One of the key challenges which still remain is the fact that the first thing that you need to do is to have a high index of suspicion. That is very important, because if you do not suspect, and as was brought out by Dr. Nitesh in his presentation also, the symptoms of ILD could well precede the onset of RA or collagen tissue disease by almost 2 to 3 years. So the patient may have non-specific symptoms. Early symptoms of RA-ILD such as cough, dyspnea, and fatigue are non-specific and can be attributed to other conditions as well. There may be an overlap with RA symptoms itself, and there may be very subtle lung involvement. As far as the radiological challenges are concerned, there is non-specific imaging finding. There may be variability in the lung involvement, and pathologically it is so heterogeneous. So it may not be possible to, identify that, yes, this is this type of ILD, or this is because of rheumatoid arthritis. There could also be an overlap with other lung conditions, like IPF, etc. And the serological challenges are, there is no specific biomarker for RA-ILD, making it difficult to establish a definitive diagnosis. And there is also variability in the autoantibody profiles. The other challenge is, of course, limited awareness and delayed referral to specialists. All these are the key challenges in diagnosing early RAILD.
Yes, sir. I was about to go there, but thank you, sir. Thanks for that very crystal clear information about the challenges that one may encounter as a clinician. So, from serology to clinical presentation and then further evaluation in imaging as well. And that is very, very helpful, sir. And since Dr. Nitesh has said wonderful talk, so I would directly jump and then request or ask Dr. Devi Jyoti to comment on what is the first line of management. You have a patient, you know that we have diagnosed interstitial lung disease in the rheumatoid arthritis patient, and then what is your thinking process, and then how do you manage, what is the first line therapy?
Thank you so much, sir, for this question. Over the years, the treatment, first line treatment and also the further treatment has changed a lot in these diseases, and there is too much confusion regarding this. Most of the confusion has been sorted out by Dr. Nitesh's presentation. As he has already said, first, if we diagnose ILD, we have to see if it is subclinical or is it significant. So if it is a subclinical incidental ILD, we should continue the DMARD, which has been continuing for the treatment of articular RA. If it is significant, we have to treat that RA ILD. If there are respiratory symptoms, if there is abnormality in the pulmonary function test, then we need to treat it. So short-term glucocorticoid should be used. If the ILD pattern is OP or NSIP, obviously a higher dose of steroid can be used. But even if it is UIP, which is the most common form in RA ILD, short-term glucocorticoid for less than 3 months should be used with other immunosuppressants, as we will discuss. So coming to the other DMARDs, we have to remember 4. Mycophenolate mofetil, azathioprine, rituximab. These 3 are the first line treatment for rheumatoid arthritis. If we can't use these 3, we can also go for cyclophosphamide. But all the other which we mostly see, like methotrexate, leflunomide, which are used for articular part of the rheumatoid arthritis, they shouldn't be used as first-line treatment for RA-ILDs. This is very, very important and a major change over the years.
Yeah. So, thank you, Dr. Devi Jyoti. And in the interest of, to sum up, I would love to show one slide so that the young pulmonologists would understand better. So this is a slide Dr. Nitesh has shown to us very clearly, and here if you see in the rheumatoid arthritis, the first line, if there is an ILD, is there mycophenolate or azathioprine or rituximab, and then additional options can be cyclophosphamide. But of late, for the past many years, 3-4 years, particularly after the American College of Rheumatology guidelines have come into picture, the cyclophosphamide usage in presence of rituximab have come down very, very drastically. And then, as Dr. Devi Jyoti has clearly mentioned, short-term glucocorticoids can be considered, but long-term glucocorticoids are definitely detrimental in presence of RA-ILD. So, and next question to Dr. Komal. In this webinar, wherever the infections comes, I will be taking the help of Dr. Komal Shah, because she is the specialist both in pulmonology and also ID specialist. So that's why. So Dr. Komal, RA-ILD particularly presents a therapeutic challenge due to balance between immunosuppression and the infection risk. If you suppress the immune system more, the chance of infections will go up. If you underutilize the immunosuppression, the chance of disease flare-ups are high. So, as a expert clinician, so how do you approach treatment decisions, especially when there is a chronic stable ILD is going on, and also sometimes there may be exacerbations in these patients as well. Over to you.
Thank you, sir, for the question. And excellent question. As you mentioned, we have to keep a balance between the infection, risk of infection and immunosuppression. So first we must know that is the patient is already having some additional risk factors for the infection. Like if patient is having uncontrolled diabetes or alongside another like renal failure or malignancy, or patient is history of tuberculosis or from the crowded low economical class. So if the patient is having additional immunosuppression, then we must be very careful in giving immunosuppression to this patient. However, as mentioned earlier, we have to give. So for the chronic stable ILD, we would like to give lowest possible dose of steroid whenever possible. And if we have to give steroids for the long time, then better to use steroid sparing agents in that case. So rituximab is the best drug over here, where it has the least chance of infection out of all the immunosuppressants. Now, when the patient is presenting in exacerbations, first we must rule out whether it is exacerbation or it is acute infection. So for that, we must first, in the algorithm, we must rule out infection. We must treat that infection. And if it is not an infection, it is just plain exacerbation, again, we are going to give high dose of immunosuppression there. So we can treat with empirical antibiotics there when the patient is going to be in the ICU for quite some time. So this is how we have to balance between the immunosuppression and the infection.
Komal, quickly, so do you depend on biofire, cultures, or BAL to rule out infection in this patient?
So in this patient, sir, we have to start from the starting, like from the onset of symptoms, whether it is gradual progression or it is acute. Like if the patient is having high grade fevers, purulent expectoration, pleuritic chest pain. On those basis, if there is some new onset bronchial breath sounds or some new findings on CT scans like consolidation, new infiltrates, anything, then and of course the cultures. Procalcitonin is a very good marker for the infection in case of bacterial infections. Patients coming in septic shock. So then definitely we can look for infection with this kind of the algorithm.
What Dr. Komal clearly mentioned is, so whenever there is an exacerbation, ensure that there is an infection. So before optimizing the immunosuppression. In my practice, when an infection is clear-cutly evident, I will stop the immunosuppression temporarily. I'll optimize under the antibiotic care, stabilize the patient before restarting the immunomodulation. That is a very, very practical take-home point. Thank you, Dr. Komal, and welcome, Dr. Mihir. So, what are the various clinical and radiological methods to use diagnosis of ILD?
Thank you, sir, and thank you to Amita ma'am and the entire ICS for this opportunity. So, as we've had an excellent presentation by Dr. Nitesh, and it has mostly cleared most of these things as far as diagnosis is concerned. There is a clinical challenge. These patients often are deconditioned. Because of their articular manifestations, they may not be moving as much to give you the regular signs that you would with an interstitial lung disease as far as dyspnea is concerned. But yes, they will still come to you with a dry hacking cough, which could be for a long period. If there are patients who have a certain amount of mobility, to reach a grade 3 dyspnea, grade 4 dyspnea is something that you could find. Eventually, of course, when you are examining these patients, listening for crackles in the basal areas, because you know that you have UIP as a more commonly found pattern, you are likely to find that in them. A lot of these patients come with a combined small airway obstruction disease as well. So you will hear them coming with squeaks, some wheezes, and that could at times correlate with an NSIP eventually when you do a CT for these patients. Now, as far as what is the threshold that one wants to keep for trying to identify an ILD when you are seeing a patient, they did come up with those guidelines in 2023 with the ACR, where they told us that if there was a patient who had an older age onset of rheumatoid arthritis, it was a male had a really high RF or CCP level. This patient was an active smoker as well. Then these are the kind of patients, and in fact, I think they even spoke about the BMI, a higher BMI patient also. For all of these patients, one would want to consider them to be at high risk for developing an interstitial lung disease in their life of RA. And these patients, one can consider screening with a CT chest upfront. It was can consider, but eventually when you combine it with your clinical signs, with the symptoms that this patient has come, it might be fruitful to do the CT. What kind of radiological diagnosis one would want? We tend to follow the same pattern. We do an X-ray, we see the X-ray. If you find there is something that is matching, you can move forward for a CT when a patient who is otherwise a low suspicion for interstitial lung. For those who you have a high suspicion for interstitial lung, doing an HRCT chest with a good ILD protocol is something that one would want to do. So that would be something.
Summary. Fantastic summary. Those patients who have got low risk of ILD, just do an X-ray and then follow them clinically. If they have a high risk of having an ILD, then those patients you go for upfront before developing even symptoms. You can just go for a screening CT. Fantastic summary, Dr. Mihir. And after that wonderful presentation from Dr. Nitesh, I would love to have, Nitesh, can you please recall any very challenging critical scenario or interesting case of RA-ILD in your practice, and that has given a lot of learning experience for you? Can you please sum up? Unmute, please.
Been quite a few RA cases in our follow-up. One of the patients is about 7 years follow-up right now. So the problem with them was when initially they came, methotrexate was a drug of choice, so it used to be given. Then patient developed progressive ILD. Methotrexate was stopped, but patient developed the rheumatoid symptoms. He had flare of joint pains. So then he has to be discussed with radiologist. Patient was not willing to go for any other option apart from methotrexate because of the cost issues with the patient. So we had to actually do a biopsy to prove whether it was drug-induced ILD or whether it was an RA-ILD only. So in the biopsy, it was shown it was drug-induced ILD. So methotrexate was out of the option for the patient. We had to convince the patient, and he was then started on the JAK inhibitors, and he symptomatically improved. So that was something when you follow up the patient for a longer time in RA-ILD, you will face one of these situations one day or the other. It's in short term that you don't see a lot of changes, but once they become longer, 7 years, 8 years, then you start changes, and that is where you have to go back to such webinars to have a revision, both for making as well as for treating the patient.
Thank you for sharing such a good case scenario. So I would love to convey in one of my cases, what has happened was, so patient was having asthma and also since childhood, around 60 years female, and chronic asthma, and then she also developed the RA-ILD. So this is a scenario where it is very, very difficult. You need to place the patient on steroids, and then outside what has happened was, this patient was treated left and right with oral corticosteroids for recurrent even ILD exacerbations. So rather what we have done is, we have used inhaled corticosteroids to stabilize the lungs, and also for ILD component, we have stopped the steroids. That has made significant benefit, and then patient did really good. Of course, patient is receiving MMF, and she did receive the Ritixi, and currently on MMF maintenance around 720 BD along with nintedanib. She's doing amazingly well. So this is very, very important. Steroids, the moment, even if the patient is asthmatic, so please use steroids only for very brief time. Do not use repeated usage of steroids, even as probably how we use for acute severe asthma, like 40 mg once daily of Vislone for 4-5 days, also sometimes detrimental in these patients. And sir, coming back to Tampi sir, can you please enlighten us regarding what are the various risk factors for developing RA-ILD, and please suggest whether we need to screen asymptomatic patients as well. Sir, unmute, sir, please.
Yeah, that's a very interesting question, particularly the risk factors. Now, various risk factors have been, identified as predictors of the development of ILD in rheumatoid arthritis, or also some of them have been found to be leading on to the severity of the ILD that the patient develops. So some of them are like elderly age group, above 65 years, would probably, I would expect this patient to develop an ILD, and it could be a severe form as well. Though rheumatoid arthritis is more commonly seen in females, however, the ILD that develops in rheumatoid arthritis is more common in the male gender, and it's almost like something like 3:1, male is to female, right? High rheumatoid factor levels also give us a clue that this patient is likely to go in to develop ILD. And so also the anti-CCP antibody levels and titers being very high predict that there is likely to be severe ILD developing in this patient. Subcutaneous nodules is another clue, a clinical clue, which can lead on to the an ILD formation in these patients. Then, of course, certain HLAs, these are HLA-DR4 haplotype is known to be more prone to develop ILD in rheumatoid arthritis. Of course, tobacco smoking has definitely been seen to produce much more ILD in rheumatoid arthritis patients. So it is well worth to advise your patient to give up smoking at an early date so that he does not go on to develop interstitial lung disease and further handicap it. Now, the severity, of course, the development is likely to be quite severe if the FEC falls below 60% and the DLCO less than 40% in these patients. And if the 6 to 12 month worsening in FEC is more than 10% or the DLCO more than 15%, these are predictors for very severe disease and showing that their progression will be quite rapid. In fact, very often it has been said in many studies that the average lifespan once ILD is diagnosed in rheumatoid arthritis is something like 3 to 4 years. The UIP pattern particularly is known to be much more severe in its outcome than the NSIP or the organizing pneumonia, which can be treated easily with oral steroids, and they show a good response, unlike the UIP pattern. When more than 20% of the lung is affected, lung parenchyma is affected with interstitial disease, it is possible that the patient will go on to severe disease. And when particularly, as I said earlier, when there is a lack of awareness of our own medical fraternity in referring this to the specialist concerned, either a pulmonologist or a respiratory physician, then when there is a diagnostic delay, more than 24 months, that also can be, lead on to severe disease in these patients. So once we know that these are the risk factors, now screening asymptomatic patients was the second part of the question. Now, as Dr. Nitesh has mentioned, a lot of these patients, in his presentation he had mentioned that we pick up a lot of patients on HRCT chest, which, as I told you, was a turning point in the diagnosis and the follow-up of ILD patients, not only in CT-ILD but in RALD as well. So you pick up a lot of findings if you do an HRCT when you suspect a high index of suspicion. You do an HRCT chest and you see patients developing early ILD, particularly your rheumatoid arthritis patients. They may not be complaining of any symptoms. There may be no cough, no breathlessness. They may not have any dyspnea at all. But these are the patients that you need to screen and progressively follow them up, because they are likely to develop full-fledged ILD in the near future. So you need to treat the underlying disease, rheumatoid arthritis, aggressively and follow up the ILD so that you pick it up at much earlier stage and you introduce the specific treatment for ILD in these patients.
Right, sir. Thank you. Thank you so much, sir, for the detailed explanation. So, it is very, very important to identify the disease at the earliest, as early as possible. Otherwise, there is a fair chances that you can miss the boat with the more than, as sir mentioned rightly, so many parameters, particularly in this high risk group, going for a screening CT scan may be beneficial, and keep a low threshold in ordering the investigations and then evaluating this patient to ensure that we diagnose early and then to stabilize the lungs without any delay. So now I would love to have the inputs from. Yes, we have a patient who is receiving a, mycophenolate 720 mg twice daily. Okay, and despite that, patient is progressively he is losing lung function. His symptoms have not been stabilized. Cough, breathlessness is slightly worsening, and I request Devi Jyoti to respond. What is the next thought process? How to manage such patients?
Thank you, sir. So first, we also need to address the comorbidities or the other parameters. Like if the patient is a smoker, smoking cessation helps a lot. We can think about rehab. All those, if GERD is causing the cough, increase in cough, and all those parameters have to be taken into account. Second most important point is long-term glucocorticoid is not the answer. Glucocorticoids have to be used even in progressive disease, or if the patient, even if he or she is not responding, only during the disease flare up, or when we want to bridge it, when we are starting a new therapy, long term should never be used. And coming to the various DMARDs, mycophenolate mofetil, rituximab, and cyclophosphamide can be used. Cyclophosphamide cannot be combined with any other drug. We can add MMF with rituximab, as it was presented in the case by Dr. Nitesh also. If we have UIP pattern, we are seeing progressive severe fibrosis, we can add nintedanib or pirfenidone. And in a few studies, tocilizumab has also been used. So all these can be used if the patient is not responding or getting better. Other than that, we can also think of lung transplant, and early referral for lung transplant should be done. Most of us wait till the patient is on long-term oxygen. It shouldn't be the case.
We'll come to transplant. Patient is still stable, not yet requiring any transplant. We'll stabilize him in this step, and then we'll move forward. Now, again, it's sort of somewhat repetition, but again, I request Dr. Komal Shah to comment on how do you differentiate between ILD flare and infection in patient with RA-ILD? What are the red flags for clinicians to watch for? And to be precise, which patients are going to exacerbate, which patients are going to infection prone? How to take that clinically, how to watch for, and then what are the various things that you look in your patients?
Thank you, sir. So again, we'll start from the history. When the patient presents, we have to start from the history, whether it is the gradual progression of the disease or whether it is acute presentation, whether there was some exposure, whether the patient was traveling, or there was some kind of history like that. Secondly, the presentation. Again, high-grade fever, purulent expectoration, pleuritic chest pain, new onset of crepitations that were not present in the patient before, some bronchial breath sounds, this kind of signs, plus HRCT or X-ray showing new consolidation, infiltrates, tree bud appearance, or the cultures being positive, procal, ESR, everything. ESR can be high in either way, but in the cases of infection, it will be higher. then WBC will be more on the left shift in cases of infection. Cultures will be positive. So and those patients who are having ILD flare, obviously they will not respond to the antibiotics. The patients with infections obviously will be responding more to the antibiotics. So these are some red flags. When the patient presents to us, we have to start from top to bottom and we have to look for infection.
Thank you, Komal, again for reiterating. You have to rule out infection when there is an exacerbation. If there is no infection, then you have to optimize the immunomodulation. Yeah. So that is the take home there. And now I request Mihir to respond. With the emerging therapies like antifibrotics and newer biologics, where do you see the RA-ILD management heading in the future?
Thank you, sir, for the question. So, it's an interesting question and it's an interesting thought, really. Primarily, I think a few years back, there was an article in JAMA which had a really interesting take on retrospective data over 20,000 patients who had received about synthetic DMARDs and biologicals. And they tried to assess how many of them eventually developed an interstitial lung disease as such. And from that data, they found out that tofacitinib receiving patients tended to develop interstitial lung disease at a lower rate as compared to the other biologicals and other drugs that they were using. So I would think that if we are to think of what would be the next big thing as far as RA-ILD and therapy is concerned in the next 10 years, it would be to consolidate this data in prospective evaluations and to find out whether we can, as with most diseases, prevent something before we start treating it. So understanding whether we can genuinely stop the development of interstitial lung, that is something that would be a great goal to achieve. Probably the second interesting aspect to RA-ILD and newer advances would be that there is a good pool of data now showing us that there is a genetic component which is similar to UIP IPFs and RA-ILD, and whether there is something targetable from that front. And given that we have been having good advances as far as therapies are concerned, maybe looking at that aspect would be something that one would want to look at as well. As we've already discussed, they had a trial with pirfenidone and RA, and they had to stop because of slow recruitment. And nintedanib as a part of our impulses inbuild has already given us some data. So yes, antifibrotics have a role, but less reparative, more preventive in further fibrosis. So maybe a reparative role is something that one would want to focus on, and biologicals and prevention of interstitial lung, that is an interesting take, I feel, is something we can look for.
So, Mihir, the clarity you have given, okay, yeah, of course, there is a lot of confusion to what way we are going to head. But the future, as per you say, the future looks very promising because there is something that may come in near or further future for ILD patients where probably we can manage the either genetic system or immune system to such a way that the ILD will not be triggered and then ILD will not progress. Maybe future is really optimistic. Let's be optimistic. We being ICScians, so we should be optimistic. And can I take the opinion from Nitesh? What is the most unusual or misleading clinical presentation of RA-ILD that you have encountered? And also, please comment on rheumatoid pleural effusion, which, to be honest, I have seen only one case in my entire practice.
So yes, so that was my answer. So we had one case of rheumatoid pleural effusion. Again, something which is very, very uncommon. The pathologist was asked to confirm it twice, thrice. They said, no, it's 100% rheumatoid pleural effusion only. And patient never complained of any joint pains. It is only after a lot of probing that patient complained that yes, there was large joint pains and small joint hand pains. So that was a unique case where extrapulmonary manifestation or extrathoracic where we could see was rheumatoid pleurisy. Rarely seen, difficult to prove, but once seen, you always inquire in every patient.
True. Thank you, Nitesh. So, Sir Tampi, sir, how do you define and differentiate between rapidly progressing ILD and progressive pulmonary fibrosis in RA-ILD? And how can we manage the RPILD, sir? Rapidly progressing ILD. And of course, Nitesh has given wonderful insights in his talk. For the interest of our delegates who have joined, I need your response to explain them what is the way forward when they really get exposed to progressive pulmonary fibrosis or rapidly progressing ILD in RA.
This is a real challenge, real world challenge for the clinician who's managing the patient, whether he's dealing with a rapidly progressive ILD, what is known as RP-ILD, or is it a progressive pulmonary fibrosis, which we often see in these patients. So to identify rapidly progressive ILD, actually it represents a subpopulation of ILD characterized by rapid progression from a patient who was probably breathing room air, or a patient's baseline oxygen requirement suddenly jumps up to a high oxygen requirement, or even intubation and ventilation within days or weeks. Without a documented alternative cause, example, as infection, which Komal would have picked up, or heart failure, that our fellow cardiologists would have, picked up early, right? So, in the absence of an alternative diagnosis, such rapid progress of symptoms and the patient landing up from room air oxygen to an intubation in a few weeks, days to weeks, without any other alternative diagnosis, one should think in terms of a rapidly progressive fibrosis. And this can be seen in acute interstitial pneumonia, whereas progressive pulmonary fibrosis and progressive fibrosing ILD differ from RP-ILD, and these items are not, terms cannot be interchangeably used. RP-ILD is a specific entity, whereas the others may be chronic and they may also have flare-ups, as was discussed by Komal, how to differentiate between infection and Now, having said that, how to manage these patients? Now, it is very important that this is the flare-up that we need to understand, and therefore, you need to hammer them with IV glucocorticoids at this stage, maybe methylprednisolone or tolumetrol. You might have to give them heavy doses of it for 3 to 5 days, and then gradually taper it down. But you will also need to take the help of 1 or 2 other alternative drugs which have been mentioned by my previous speakers, like rituximab, cyclophosphamide, IVIG, mycophenolate, and JAK inhibitors or calcineurin inhibitors. Now, if there is no severe disease, then this will do. But if you have severe disease or a high suspicion of anti-MDA5 disease, then IV glucocorticoids plus at least 2 additional therapies, which include rituximab, cyclophosphamide, IVIG, mycophenolate, JAK inhibitors, or calcineurin inhibitors. So you need to pick up at least 2 more along with the glucocorticoids, and that is how to successfully manage these patients and bring them down to the base level.
Sir, with your permission, I just want to bring the slides, sir, so that delegates can take a screenshot if they would have missed taking from Dr. Nitesh. Can I, sir?
Yes, sir, please. I think that will clear any doubts regarding RP-ILD and also how we go about managing it in a systematic way.
Yes, sir. I'll just bring that slide in a moment. Meanwhile, I'll take the opinion from Dr. Devi Jyoti. How often do you come across, Dr. Jyoti, regarding the RA nodules, and what are the various challenges that you encounter while diagnosing, and your opinion, please?
So, I have seen one case of RA nodule. In the literature, it has been said that about 20% of RA patients have RA nodule, and it is more common in men, younger men, in whom a rheumatoid factor is positive in the blood, and in those who are smokers. And almost 80% of patients who have a rheumatoid nodule in the lung, they have subcutaneous rheumatoid nodule also. So histopathologically, be it subcutaneous or be it lung, the nodule is absolutely similar, and it shows necrosis surrounded by palisading epithelioid fibroblast with chronic inflammatory cells like lymphocytes. Mostly in the lung, it is in the upper lobe, mid or upper section, and towards the periphery with contact with the pleura. And mostly it remains asymptomatic. It may stable. It may remain stable or may even resolve on its own. When it cavitates or when it goes into the pleura, the symptoms begin. So coming to the next part of your question, where you asked about the diagnostic challenges, as it is more commonly found in smokers, men, and those risk factors are also common in malignancy. So it is very commonly confused with malignancy. The typical features which favor rheumatoid nodule is presence of satellite lesions, multiple nodules, mostly more than equal to 4 in numbers. They have smooth border, mostly peripherally located with contact with the pleura. There can be calcification or cavitation. These are mostly less FDG avid, and typically FDG avid lymph nodes are typically absent. So all these features favor rheumatoid nodule. As I have already described the histopathological features, it is very often confused with tubercular nodule also.
Okay.
Also, we have a few drugs like methotrexate, leflunomide, which can increase the size or progression of the nodule. In those cases, we may have to stop if it is being used for the treatment of the articular part.
Right. Thank you, Dr. Devi Jyoti. And another important thing I would just like to add is these nodules have a tendency to necrose, cavitate, and rupture. Since they are present in the subpleural area, there's a fair chances they can give rise to the pneumothorax. So that's why be cautious, and those patients who have necrotizing nodules in the subpleural areas, you should warn them that this may give rise to pneumothorax in advance of, actual pneumothorax. So thank you, Dr. Devi. And now the one of the very, very challenging scenarios goes to Dr. Komal Shah. So do you suggest in your practice ruling out active tuberculosis or latent tuberculosis before initiating the treatment, the second line agents, or for that matter, first line agents in RA? And please also throw some light on importance of latent tubercular bacterial infection in the practice.
Thank you, sir, for the question. It's very, very important because it's quite confusing as well. So, as per the guidelines of NTP, which was released in July 2021, for the tubercular preventive therapy, that is TPT. So first we must, whenever the patient is having any form of immunosuppression, now we are talking about RA-ILD and the patient who is on immunosuppression, but otherwise also, if the patient is HIV positive, if the patient is in close contact with tuberculosis patient, or the patient is having this form of immunosuppression, we must first rule out active tuberculosis and before starting the immunosuppression. Now how to rule out? Again, symptomatic, we can do chest x-ray. If in the private, so this is provided in the government institutes, but when patient in the private, you can also do USG neck and USG abdomen to rule out if there are any lymph nodes. So once we are ruling out active infection, after that we can do Montauk's or IGRA. With Montauk's or IGRA test, we can also rule out latent. Now the catch comes here. So if the patient is not having active infection, patient is having IGRA also negative, Montauk's also negative, then the physician can decide not to give TPT also, because everything is negative. But if the patient is in contact with a TB patient or in endemic country like India, we should be giving tuberculosis preventive therapy in those patients. So the final step is on us whether we want to give or we can stop. So first rule out active infection, then rule out latent infection, and then if Montox and IGRA is positive, definitely we will treat. If it is negative, we can still take a call whether we need to give or not. Now, what are the treatment that is provided in the program? That is, first is 3 HP. Matlab 3 months we have to give every week isoniazid and rifampicin. That is 300 milligram each of the drug, and it is a fixed drug combination which we have to give once a week. So that will be 36 doses. Or we can give plain isoniazid for 6 months. So this is how we treat the latent tuberculosis. We can prevent the tuberculosis infection in patients whom we are suspecting to have latent tuberculosis infection, and those who are going to receive the immunosuppression.
There are a lot of issues, and one complete webinar is required to discuss about LTBI.
Yes.
So we will not go into it, but if there is any rise of suspicion, any suggestion that this patient has got exposure either in the form of MON2 positive or IGRA positive, or there is a close contact even if MON2 is negative, IGRA negative. So upfront, please treat it before starting immunomodulation. That's what Dr. Komal says.
Yes.
Thank you, Komal. And
Yes.
coming to next important question. Yes, rheumatoid arthritis can present in seriously, we discussed. So in which patients, we should suspect the early or the chance of having a ILD in RA patient? Over to Dr. Mihir. Since this is sort of repetition, I request you to be very crisp.
Yeah, so just to repeat what we had said as far as the ACR is concerned, if you have a patient, you've diagnosed rheumatoid arthritis on articular symptoms, if you have a high RF, high anti-CCP, this patient has had RA at an older age, has a high BMI, is a smoker, has a high DAS also, so more than 28 as Dr. Nitesh said, then in all of these patients, one would want to have a higher clinical suspicion of interstitial lung. The patient has a hacking cough, which is not going, they are deconditioned. They may not sometimes complain about breathlessness, but these patients often come with significant fatigue and tiredness. That could also be a surrogate marker for them actually being breathless when they're working, and they cannot really differentiate between those two. So look at these things with those kind of lenses, try and discover whether there is genuinely a component of them having some exercise DSAT, and that would help you identify whether these patients could be developing an interstitial lung.
Fantastic. So the easiest test, as Dr. Mihir suggested, exercise-induced desaturation. Like make the patient to in your office itself sit and stand, or ask him to go for a quick walk of one stair up or one stair down kind of thing. Go and come back and then assess quickly. If there is an exercise-induced desaturation, that's a wonderful point, Mihir, which we can do it in a matter of 1-2 minutes in our office itself. Thank you for that brilliant input. Now, Dr. Nitesh, with biologics like rituximab and JAK inhibitors being used in RA, how do they impact ILD progression? Yes, you have covered brilliantly, but for the sake of again repetition and for our delegates, please respond. And are there any drugs that we should not be used in RA-ILD as immunomodulation?
So as per the ACR guidelines, your TNF alpha inhibitors should not be used in patients with RA-ILD. What you can use is JAK inhibitor. Also, MMF, rituximab remains your first line therapy. So if your patient can have rituximab or MMF, these are first line. If your JAK inhibitors are second line, they are not that effective as MMF and this thing. But TNF alpha inhibitors should not be avoided in case of RA-ILD.
Okay. And how they are going to impact in ILD progression?
So they all these three have Yes, so they have shown to reduce the fall and decline in FVC as well as DLCO, clinically non-randomized studies. So that is why the evidence is still low against them.
Right. Thank you so much, Dr. Nitesh. And Sir Tampi sir, so antifibrotics like nintedanib and pirfenidone are being explored in RA-ILD. So as one of our colleague was mentioning about inbuilt trial, and may I ask you, in your experience, do they really have created some impact, and what do the guidelines recommend? Please unmute yourself, sir.
So that's an interesting question. And we know that when antifibrotics came up initially, they were only used for idiopathic pulmonary fibrosis. And it was not extending to any other kind of pulmonary fibrosis. But subsequently, it was the systemic sclerosis was the first CT-ILD where nintedanib was cleared to be used. Subsequently, over a period of time, they have found that both Pirfenex and nintedanib could be used and have been approved, off-label and approved for the use in rheumatoid arthritis. Now, we know that these might not only prevent disease progression, by inhibiting fibroblast proliferation, by reducing fibrogenic growth factors and modulating the immune responses. By all these mechanisms, they tend to slow the disease progression, reduce the decline in lung function, improve the lung function sometimes, and reduce the mortality in RA-ILD patients. However, the inbuilt trial has shown us it was the nintedanib versus placebo in progressive pulmonary fibrosis, 13% of whom were RA-ILDs from various different countries, 15 different countries to be precise. So in that trial, the annual rate of FVC decline was lower in the ones that were given the nintedanib in these patients. However, the problem is that these antifibrotics need to be monitored. They have their own adverse events, which we are all aware of. Their liver enzymes need to be monitored. Gastrointestinal symptoms, particularly diarrhea, is a problem with both the drugs, predominantly nintedanib. It can happen with nausea, GI symptoms, and diarrhea with Pirfenex. But the photosensitivity is the problem with Pirfenex. So one has to be careful. Various skin reactions like rash and pruritus can happen. Now, however, whereas nintedanib was the inbuilt study, Pirfenex was studied in unclassifiable ILDs. And there, which was a phase 2 randomized control trial, 253 patients of progressive pulmonary fibrosis. And here they found that it managed to reduce the FVC decline by 87.7 ml in treatment arm and the FVC by 157.1 ml with the placebo. So you can imagine there was a definite difference in the drop in the FVC with the placebo as compared to Pirfenex. And therefore, when the progressive fibrosis RILD progresses despite the optimum treatment, there is a definite role for introducing antifibrotic under close supervision and monitoring.
Thank you, sir. That's a brilliant summary of when to use antifibrotics, either nintedanib or Pirfenex. And whenever you initiate the antifibrotics, ensure that you monitor these patients for side effects, alert them for the side effects regarding gastric intolerance and then loose motions and photosensitivity as well, and then follow them up so that whenever you convey that these are the possible side effects, then it makes the patient to understand what are the possible side effects that they can expect from these drugs, so that they will report to us at appropriate time. And next interesting question for Dr. Devi Jyoti is, There are many HRCT patterns that we can come across in RA-ILD. But yes, some they can resemble UAP pattern as we see in idiopathic pulmonary fibrosis. May I request you that what are the key differentiating features, and please also comment on various patterns that we come across in HRCTs.
Thank you, sir. So the most common ILD pattern is UIP in RA, and the various other patterns are NSIP, OP, or LIP. So presence of rheumatoid nodule and pleural disease can help differentiate between rheumatoid ILD and IPF. Chung et al. Has described brilliantly about 3 specific features which favors RA-ILD than IPF. The first one being exuberant honeycombing. So if there is a lot of profuse honeycombing. Second is straight edge sign. So here what happens when you see on a coronal section, the involved lung makes a straight interface with the normal lung with less or no superior extension of the disease. So you get a horizontal straight line. So it is a straight edge sign. The third being mostly anterior upper lobe involvement. If these signs, these features are present in your HRCT, these favor RA UIP than an IPF. So these are very important to know also for the exam and also practically, clinically.
Practically, absolutely brilliant points. But we also see sometimes, NSAP pattern. We also see organizing pneumonia patterns. It is not uncommon to come across these findings in RA-ILD. So whatever the pattern, okay, it's very, very important to identify and address accordingly to the pattern, because NSAP, as Dr. Nitesh has brilliantly concluded in his talk, NSAP and an organizing pneumonia is going to respond very well with the steroids. And of course, whenever there is a UAP pattern, you should be little more cautious of using steroids. And
sir, can I ask one question here?
Please.
Yeah. So, what are the possibilities of RA-ILD presenting as diffuse alveolar damage? Like we had one patient in whom we suspected that after the postmortem, like when we did the biopsy after his death, we found a DAD and his NTCCP was positive. So is it possible, like what are the percentage, if any one of you have come across such case?
Nitesh, you would like to respond? Yeah.
Yes. So literature has reported to be less than 5% present as diffuse alveolar damage.
Right.
But sir, have you come across any case like?
No, we have found other causes of diffuse alveolar damage, not RA till now.
Okay.
Right. So very uncommon presentation, and that's a wonderful point, Komal. Okay, really appreciate. And delegates, please, okay, audience, please stay tuned to it. We have a brilliant show coming up. We are going to ask all the questions which you have posted. Okay, another important announcement from Harshal Gangude from Cipla is, so far there are 1881 logins, and from the beginning of 1500 now it is 1881. They're continuously listening to us. Superb show, brilliant efforts, Cipla and then entire team. Dr. Amita Nene, kudos to you, and then Dr. Sambhadia sir, and then Rajendra sir. Thank you so much. And then next question goes to again Komal. Okay, do infections contribute to disease progression in RA-ILD? Okay, or they are resultant from the treatment complication or immunomodulation?
So both ways, infections do contribute in progression of disease in a way that after the infection, because of infection, it triggers inflammation and fibrosis. And sometimes infections like COVID, there is residual fibrosis. So there are studies which suggest that repeated infections lead to decreased lung functions in established RA-ILD patients. So they do contribute for the progression, and they are also as the result of immunosuppression.
Yeah, Thank you. And I could get my PowerPoint back. 1 second, I will summarize this slide. Um, is the slide visible?
Yes, sir.
Yeah, now it is visible.
Right, right. So this is what Dr. Tampi sir was mentioning regarding management of rapidly progressive ILD. Okay. Whenever you suspect a severe disease, then what happens is if you suspect severe disease, if there is no severe disease, but you are suspecting rapidly progression, so what happens is start depend on IV glucocorticoids and take the help of 1 or 2 additional therapies. It is not mandatory in a non-severe disease to use 2 additional therapies. IV glucocorticoids to stabilize plus either rituximab or IVIG or mycophenolate, cyclophosphamide as because it is less popular nowadays, but as per the guidelines, you can still use it, and TAC you can use or JAK inhibitors you can use. But if the patient is experiencing rapidly progressive ILD with severe form of disease, then it comes very pertinent or very important to combine 2 additional therapies in addition to IV glucocorticoids, that is rituximab, cyclo, IVIG, mycophenolate, calcineurin inhibitor and JAK inhibitor. But remember, whenever you want to pick cyclophosphamide, do not combine with additional immunomodulation. But otherwise, rituxi plus mycophenolate, rituxi plus TAC, rituxi plus JAK inhibitors, and then meanwhile, it is very important for you to understand this rapidly progressive ILD, despite whatever the management that you could offer to the patient, the chance of stabilizing is not even 50%. So in such scenario, please tune the family members, please counsel the family members that this is a patient where he may be right candidate for lung transplant referral, and then ensure that you have initiated that discussion with your patient family. That's very important. And coming to Dr. Mihir, in your experience, what are the most common triggers of acute exacerbation RA-ILD, and do you still manage with pulse steroids in acute flare-up, and what is the best way forward? Unmute, please.
Sorry.
Yeah.
So in my experience, generally most of our rheumatoid arthritis interstitial lungs have come with infective exacerbations more commonly. So when it's an acute exacerbation, as is standard, one wants to identify the cause of the exacerbation. So infective viral exacerbations tend to be reasonably common with us. We do have a lot of patients on immunosuppression, so bacterial exacerbation is not unknown. A lot of these patients are in and out of the hospital frequently, so they do come with drug-resistant organisms as well, which almost appears community acquired, but more often than not, it's because they've been in the hospital too. As far as acute exacerbation of the interstitial lung is concerned, once we have possibly ruled out that there is no infection, a lot of our definitions are borrowed from acute exacerbation of IPF, because we don't really have a proper definition otherwise. So something that has come up within the previous month, you've got bilateral disease, you've ruled out an infection, you don't have heart failure, all of these, no signs of fluid overload. With all of these, if you're thinking of an acute exacerbation, yes, methylprednisolone is something that we still fall back to. We don't have RCT evidence perhaps, but that is something that we start off with 500 milligrams to 1 gram for the first 3 days, then drop down to 1 milligram per kg later. We know that the infectious diseases hawks are always looking at us when we are thinking of empirical antibiotics, but as a practice, when we are giving this, we do cover with broad spectrum antibiotics for these patients. And eventually, of course, when I find that there is a true catch in treating this patient, we do fall back and ask the rheumatologist for their inputs. There is some data where they have looked for RA-ILD patients in exacerbations where they have tried cyclophosphamide upfront. It's middling. Some of them have shown some response. Some of them have shown there is no difference in mortality. But this is something that I think comes with more experience. You need to have that kind of backing. You need possibly more than one head to come to this decision that, okay, MPS is something that I've tried. I need to think of something more. So maybe giving cyclophosphamide, try and bounce it off some other heads. If there is someone with more experience, always good to have more people at hand at that point.
So just to add one important thing, in my experience of probably past 15 years, I always believe cyclo works quicker, rituximab works slow. Okay, what is your take? Mihir bhai.
Per se, so that is something that we have seen as well. So we
Right.
do tend to find these patients responding faster, but again, there are several issues with this as far as the cost is concerned. So maybe the data that we have as far as rituximab is concerned is really lesser in comparison with cyclophosphamide. So I don't have the evidence to back it, but
Right.
yes, this is something that we do see.
Thank you, Mihir. So coming to Nitesh, Dr. Nitesh, okay, lung transplant, yes, is a last resort in RILD. Of course, not in this webinar. We haven't come to last. We are still midway, my dear friends. Okay, stay tuned. But many patients are referred to lung transplant when very late. So when should we start discussing transplant options to our patients?
Right. So similar to idiopathic pulmonary fibrosis, whenever you diagnose idiopathic pulmonary fibrosis, your mind should start ticking that when should I ask the patient for transplant, you explain them this is an option because that gives them the best treatment outcomes. Similar for RA-ILD also, the transplant should begin. The red riders are if your FBC is less than 60% at presentation or DLC is less than 40% at presentation, should immediately trigger the transplantation. Other parameters are you have fall in FBC of more than 10% over 6 months or fall in DLC over 15% or more than 6 months. So that those are also another trigger. Transplant is not to be done when patient has already gone into hypoxemia and is on oxygen therapy. So it should be referred early and just for other standard indications. Practically at the first instance when you diagnose, it should be one of the discussant with the patient. The ultimate treatment may require a transplant.
So thank you, Nitesh, for that brilliant explanation. Now I move to Dr. Devi Jyoti and then come back to Tampi sir. So when you are referring a patients to RA-ILD patients to transplant, there are some big contraindications. In which patients do you refrain from referring that patients to transplant? Dr. Devi?
Yes, sir. So some common general contract indication of lung transplant, they remain the same. Like if the patient has malignancy or unstable CAD or morbid obesity, chest wall deformity, psychiatric illness, not much social support, all those things. But if we speak about RA, if it is older age, there is immobility, severe extra articular, severe disease, all these cases, we should not be referring them for lung transplant. We should always see the risk benefit ratio, and the benefit should always be more than the risk.
Right. So severe patients who are crippled, okay, and these are the patients with whom you don't refer for transplant. So patients should have ideally, okay, been referred very early. Component the moment the 6-minute walk test starts deteriorating, okay, then those are the patients with 6-minute walk test of around 250 meters. So those are the patients ideally we should consider to refer to transplant. And again, those who have severe form of crippling disease, so are not good candidates for a transplant. Thank you, Dr. Devi Jyoti. And Sir Tampi sir, so drug-induced lung injury is always a concern in RA-ILD patients on DMARDs. Are there any specific red flags to suspect? And there's always there's a blame that goes on. The methotrexate has worsened the disease in RA patients. So, what is your take? Can methotrexate cause? Yes, Nitesh earlier has said 99% it is not the cause. But that 1%, how to suspect and how to take it forward in clinical scenarios, sir?
Yeah, that's usually a very challenging scenario where you have progressive ILD, progressive fibrosing ILD with probably a drug-induced, side effect of interstitial fibrosis. So it's a rare but potentially life-threatening condition and confusing to the clinician who is treating the patient. That is the challenge, And some of the drugs that you very rightly mentioned, methotrexate. Actually, methotrexate has just about 0.3 to 0.4%, involvement of lung as interstitial fibrosis. That's a very, very small number. So as Nitesh has brought out, almost 99% of them are probably not because of methotrexate induced fibrosis, and they could be fibrosis just anyway. However, that is one scenario where, in the case that he quoted, his experience that they had to resort to a lung biopsy in that particular situation and rule out drug-induced versus a rapidly progressive ILD. So autoimmune, right? So having said that, the other drugs which one could insinuate are the leflunomide. Leflunomide again should be avoided in particularly pre-existing ILD. In an RA-ILD patient where the pre-existing ILD is there, avoid the use of leflunomide. That is what the recommendations are. Also, in previously methotrexate treatment has been used and that resulted in ILD. Such patients should not be exhibited leflunomide in these patients. Sulfasalazine is another drug which pneumonia has been documented. And of course, hydroxychloroquine, it is not very usually implicated in lung fibrosis. Now, as far as these drugs are concerned, they damage the lungs and cause fibrosis by immune system deregulation, cytokine release, and oxidative stress. And we know that these patients, what are the red flags when these patients start suddenly increasing their dry or productive cough, when they have increase in shortness of breath, the fatigue, generalized fatigue, and fever, low grade. So when this kind of a thing develops on introducing a newer drug, one should suspect a drug-induced lung injury here, and one should evaluate them clinically with imaging studies like HRCT and pulmonary function tests if available. And of course, the management is logical. Withdrawal of the offending agent is the first thing, and back it up with corticosteroids and immunosuppressive therapy along with supportive care.
So thank you, sir. Thanks for that summary. So be watchful when you are dealing with methotrexate, leflunomide, and sulfasalazine. And then, unless you suspect, we cannot rule out the injury that is caused by these drugs. So we should have a clinical suspicion, though it is rare. It is not okay. It should not. It should be immediately discontinued. If there is a past history, my dear friends, do not restart such drugs. And coming to Dr. Komal, yes, Dr. Komal, patients, so far we are dealing with a lot of immunosuppressants which make the patients too prone for infections. And how can these infections can be prevented in clinical practice? What is your view?
So you want to ask me whether what infections to be treated or prevention of the infections. So basically, sir, the patients.
And what are the infections that you also see in this immunocompromised host?
Okay, so in immunocompromised hosts, usually we see the infections which are common, obviously common things common, plus the rare ones. So when we divide it, it will be like bacterial, viral, fungal, and atypical. Bacterial may again common infections as the patients will be coming from the community. So common infections like streptococcal pneumonia, Staph aureus, H. influenzae, all these common infections would be there. But if the patient is coming from the hospital or from the care center, then obviously there will be like all gram-negative infections like E. coli, Pseudomonas, Klebsiella can be possible. Viral infections, very common, like RSV, COVID, SARS-CoV-2. All these viral infections are common. We have to keep in mind patient is immunosuppressed, so there are possibilities of fungal infections. Most common in lung will be Aspergillus and mucor. And then we have to look for the atypical ones like tuberculosis, atypical mycobacteria, PCP. So we have to look for each and every infection. Now, all these patients who are immunocompromised, we have to make strategies to prevent infections. And for that, as we mentioned earlier, TB preventive therapy, vaccinations for influenza, pneumococcal vaccines, COVID vaccines. In some guidelines, they are mentioning about PCP prophylaxis for those patients who are receiving immunosuppression. And obviously, the patient should not be exposed to those who are sick. They should be taking care of themselves like that, not in the crowded exposure. And we have to keep an eye open for the infection whenever patient is coming to us. So every time we have to make sure that patient is not having any, he is not prone for the infection.
Yeah, straight point to you is, in which patients do you recommend PCP prophylaxis?
So these patients, like there are different guidelines, but these patients who are on chronic immunosuppression are having the chances of the guidelines which are for PCP prophylaxis are for most of the patients who are post-transplant patients. So there is no clear-cut guidelines here, but if we feel that patient is prone, we can give PCP prophylaxis.
Probably what I practice in my on my patients is, probably if we are using more steroids, okay, for probably 2 months, 3 months, more than 20 mg of Isolone per day kind of thing. So yes, okay, we can start. And second important thing, if more than 2 agents are being used to immunomodulate, then definitely these are the patients who would really benefit from PCP prophylaxis, because again, the cetron or Bactrim will also have a lot of side effects. Be watchful about the side effects before initiating the PCP prophylaxis. Thank you, Dr. Komal. And now I would request Dr. Mihir to comment on. Yes, briefly, Dr. Komal has mentioned about what vaccinations do you use in your RA-ILD patients, and what other ancillary interventions do you recommend to patient to feel breath-free and then more energetic?
Right. So as Komal Ma'am has already told us that these patients do require to be vaccinated. As far as my practice is concerned, we tend to use pneumococcal vaccination and influenza vaccination as we would do with most. Of late, I've started using the recombinant zoster vaccine as well for these patients who have been on immunosuppression. So that's something that we would do. Ancillary aspects to treatment for these patients. Yes, if you have a patient who has exercise desaturation, ambulatory oxygen is an option that you can provide to these patients. Long-term oxygen therapy for your patients who meet the criteria of them being hypoxic or having pulmonary hypertension and still being around 88-89% saturation. So those patients, you can consider giving them oxygen. Rehabilitation, of course, for your patients. These patients are commonly, we've been saying that all night, they are deconditioned. They need some form of support. They often do not make the effort because they are so debilitated, and thereby getting a good rehab program is something that is crucial for them. And perhaps in addition to all of this, these patients often with their immunosuppression, with their joint disease, tend to start becoming a little more overweight. Probably assessment for obstructive sleep apnea and giving them a CPAP or a BiPAP in time also helps them, develop better energies during the day, since we are talking about being fatigue free, having a better energy system that in general helps them perform better even with their rehabs eventually and with all of their daytime activities. So that's something that one would want to screen for.
Right. Thank you, Mihir. And to Nitesh, what other comorbidities you would look forward to address? Dr. Mihir mentioned OSA should be identified and treated as well. So what other areas that you would love to focus and then address to give a comprehensive holistic care to RA-ILD patients?
So the other areas would be the musculoskeletal involvement, whether they are facing any muscle mass loss, then whether they have any osteoporosis, as can be evaluated using DEXA scan because steroids are frequently given to them. Third would be anemia of chronic disease. So many of them have anemia because either because of drug induced, because of methotrexate, or because of the lower nature of the disease. And one should also look for cardiovascular disease. The rheumatoid also has cardiovascular changes. Some patients may have coronary artery disease. Some patients may have reduced ejection fraction. Some may develop pleural effusion because of the synovitis. So we may have to look for all these factors also.
So any particular comments on GERD management?
Yes, so GERD management as part of every ILD we have to keep in a purview. So GERD management we have to take care of.
So a simple measures like adding a PPI or adding a ranitidine or famotidine kind of thing, okay, would also deal with a lot of reflux issues, and then we should ensure that we should take that extra 1 minute and then convey the patient, probably not to have full stomach meals, eat in a small quantity, ensure that their nutrition is adequately taken care, and then whenever they are sleeping, at least ensure that 2 hours ahead of sleep they should not they should have completed their dinner or meal. Okay, ensure that reflux is minimized. So wonderful point, Dr. Nitesh. And we will come to the audience questions. Plenty of people have poured a lot of questions, and thanks to each one of you, Dr. Snehil Jain from Madhya Pradesh, Dr. NT from Maharashtra, Dr. Dinesh Ravi. Okay, I am trying to address each thing. What are the prevention strategies in high risk cases? We have discussed that. Okay, early diagnosis, low threshold to keep the diagnosis of ILD is very, very important in such cases. And Dr. NT from Awadh, Maharashtra, Mumbai is asking how frequently we should do HRCT lungs in patients of RA on methotrexate. Nitesh, can you please?
So there are no such timelines where you have to do. Anytime the patient is worsening with the symptoms, you have to repeat an HRCT scan to see what type of pattern has happened in the lungs.
Right. Thank you. And Dr. Dinesh Ravi from Rajasthan, Bilwara is asking, Sir Tampi sir, please sir, comment on this. Okay, role of antifibrotic in RA related UIP. So we have discussed Dr. Dinesh Ravi. Again, for your sake, I would take the comments from Dr. Tampi sir.
Yeah, role of antifibrotic in RA related UIP. Now here, as I said, discussed in my presentation at that time when I answered the question, that definitely the antifibrotics are indicated in this kind of a setting, particularly the UIP. Of course, one should not, be enthusiastic using antifibrotics in other kind of interstitial lung diseases with RA, such as NSIP and OP. But it should be reserved for UIP and UIP alone. And there, you have this fibrosis and you have the patient symptomatic with progressive dyspnea, dry cough, and you find the lung functions are dropping, FEV1, FEC, all dropping. Then you know that you are dealing with a progressive disease. You confirm it with an HRCT. And once you have the definite evidence of fibrosis and the presence of UIP, it is mandatory to start antifibrotic. And as I said, we would use either Propinex or nintedanib in the appropriate doses while monitoring them.
Thank you, sir. So, Dr. Shreyami Saha from West Bengal, Kolkata is asking, does the patient always present with RA features first, or they can present with ILD features also? Dr. Komal, one non-infectious question to you.
No, sir. The literature says that patients can present with either RA features first or ILD features first. Like 10 to 20% of patients present as ILD first beforehand the starting of the synovitis or joint pains.
Right. Thank you, Komal. So another interesting question which we haven't covered so far is from Dr. Shreyami Saha from Bengal, Kolkata. This question I will direct to Dr. Mihir. Dr. Mihir, so how to manage the intractable cough in ILD patients? Now, after your comments, I'll add something from my end.
I feel that's a question that everybody is asking, and the patients ask you, you are asking yourself again and again. It's not only your RA-ILDs, even your IPFs. It's really difficult for their intractable cough to go. Of late, I have been using codeine more liberally for these patients, so you can consider that. It is often we miss some of the features of obstructive airway also in these patients who have interstitial lung. So if you have a patient who has interstitial lung, you could look for small airway obstruction also in them. Sometimes initiating inhalers for them also helps you manage their cough a bit. Reflux, as we said, patients with UIP, IPFs also, we know they are worsening with reflux. So these patients adding a PPI also helps them with their cough. I would think there is an element of trying to understand whether or not this patient is genuinely not controlled from the RA perspective, and whether this is actually an exacerbation. And perhaps this you might want to upscale some of your therapy as far as that is concerned as well. I don't know, sir. What are your thoughts on this?
Mihir, interestingly, okay, here she mentioned very clearly about intractable cough. Intractable cough is one of the commonest question, as you rightly mentioned, that questions come that the patients poses to us, and then in such cases, we should have out of box thinking, and there are patients who have particularly young ladies around 40-45 years with ILD. Okay, they come with a lot of apprehension. You have to manage anxiety component. And then, as Dr. Mihir rightly mentioned, the most important cause of intractable cough is GERD. You should optimize GERD. How you are going to optimize GERD is, so as I have mentioned the prophylactic and anti-reflux measures just now. And then I also suggest to add liberally use the calcium alginate, that is Gaviscon, so that the reflex component will be optimized, and the position of the patient on the bed while they sleep should be always 30 to 40 degrees head end elevation. This will prevent the cough in maximum patients. There is enough data to say in IPF, not in RA-ILD. I'm sure we can apply the same data to RA-ILD patients as well. Those patients with RA-ILD, I have in my practice as well, I have seen if we start an antifibrotic pirfenidone, particularly when compared to nintedanib, the cough control is achieved much better, much earlier. That is my experience. Despite all these things, if the patient is complaining with a cough, then probably Xylocard is one thing. But remember, my dear friends, when you are giving nebulized Xylocard or codeine liberally, what happens is there is a chances that you are also facilitating the aspirations, micro aspirations. These micro aspirations in turn is going to exacerbate the underlying ILD. So whenever you are giving codeine or Xylocard to control the cough, ensure that they should not sleep flat, or at least they should not have anything, because the local anesthetic will knocks off all the local reflexes that facilitates aspiration. So please educate them that they should not eat anything at least for 2 hours, and then they should not lie in supine position for at least 2 to 3 hours. That is my take home, and hope Dr. Shreyami, we have answered your question.
So just one more point, if I may.
Yes, sir, please.
Just add to this. Sometimes thalidomide has been used for intractable cough. So just for the sake of completion.
Yes, sir. Thank you, sir. So from Kuldeep from Haryana, Faridabad, can we give nintedanib and immunosuppressant together in RA-ILD patient? Is there any data or guidelines? We have discussed, Dr. Kuldeep bhai. Thanks for asking that wonderful question. Dr. Rida from Mumbai, Maharashtra, what patterns of of ILD are seen in RA. We have covered that. Organizing pneumonia, NSIP, UIP, or the various forms we have seen. And Dr. Shreyami again asked, what is the most common CTD presenting with ILD in India? Okay, anyone to answer? Dr. Nitesh?
Yeah, so there have been 3 registries, one from Patel Chest, one from PGI, and one the ILD India registry. All 3 have shown that RA ILD was the most common ILD, though among the ILDs it is the least common, but among the CTDs RA ILD was most common.
Right.
So that has been there on the record till now.
Right. Shahbaj from Maharashtra again asking, what is the most common presentation of RA-ILD? We discussed Dr. Shahbaj. Saurav Mukherjee is in practice in RA-ILD. Is there any guidelines when both antifibrotic may be used together? And you cannot get that. So far, there is no evidence, particularly in RA-ILD, to mention both antifibrotics can be together. We generally use out of desperate, whatever you use, the patient, or if the patient is showing progression of ILD, then sometimes we may end up in using both the ILD, both the drugs, nintedanib and pirfenidone. Bhavyaja from Maharashtra asking, what is the prevalence of ILD in RA patients and how does it impact mortality? We have discussed thoroughly in Dr. Nitesh talk. And Meena G from Navi Mumbai asking, can you discuss the shared pathogenic mechanisms between RA and ILD? For the interest of, again, repetition, I would request Dr. Nitesh to give a quick comment.
So pathogenic mechanisms is shown to be same. That's why UIP pattern and RA UIP pattern were almost similar. Genetically, if you say MUC5B gene has been most studied gene, where polymorphism of MUC5B gene leads to RAI.
Thank you, Nitesh. And Shehbaz is asking, what respiratory clinical sign to suspect in case of advanced RA-ILD? Not clear. And Shreyami again asking, what is the prognosis of a patient with fibrosing RA-ILD? We have discussed, ma'am, very clearly. We have explained through slides as well. Dr. Devi has discussed, Dr. Shah sir has discussed these points. Ronak from Punjab is asking, what are the typical pulmonary symptoms and radiographic findings in RA-ILD? We discussed, Dr. Ronak. Thank you for asking. And how Dr. Sudesh from Punjab is asking how to proceed RA-ILD with cavitating pulmonary nodule. Kindly suggest a treatment option. I think Dr. Devi has answered. Dr. Komal, can you give a quick comment on that?
So as mentioned by Dr. Devi and commented by you, sir, that in cavitating nodules, we must check for whether they are prone to get pneumothorax. So we have to be careful about it. Otherwise, the treatment remains the same.
So there probably,
and we must rule out.
If there is an underlying suspicion of probably fever or any other pathology is going on, probably NTM or tuberculosis should
or
also be ruled out.
or something
Or
like
Staph aureus can cause such a kind of cavity appearances kind of thing. Thank you, Dr. Komal. And what stage of RA-ILD need not be treated? Dr. Sham sir.
Yeah, I think we discussed this point.
Fantastic question.
And and I think our question was there that do we screen asymptomatic patients? And this is the point that needs to be mentioned, that whenever you detect the presence of ILD, the patient may not be symptomatic, but you are following up that patient regularly with follow-up scans and PFT. And you start treating them the moment these are affected and you can see that the lung functions are deteriorating or the patient is symptomatic. That stage, the RA-ILD needs to be treated from there on.
Thanks, sir. Thank you, sir. And Dr. Sanket from Maharashtra is asking, what are the ongoing challenges in diagnosing and managing RA-ILD? That's what we have done in the entire webinar, my dear friend. And Bhavyaja from Maharashtra asking, what is the role of HRCT and pulmonary function tests to monitor, to diagnose, and to treat? We have discussed. Komal Dimar from Maharashtra is asking, how do you differentiate RALD from other forms of ILD? We have discussed Dr. Komal. Shamal Singh from Gujarat is asking, what are the current treatment options of RALD? And we have discussed Dr. Shamal. Just go through the recordings one more time. Dr. Vishwesh from Maharashtra is asking, what are the current treatment options? How to choose between them? Discussed already. And I would request, since many are asking that question in the end of the webinar, Dr. Nitesh to sum up what are the broadly, okay, in a minute, what are the current treatment options for RAILD management?
So I can just reshare the slide set for just
Yes,
for,
please. Yes, please.
so that all can see through it.
Sir, actually, all those questions were sent at the onset of our webinar. So,
Oh, right. Okay. So,
Right. So this is how we begin with RAID.
Yes.
So rheumatoid arthritis, we have first line drugs as mycophenolate, azathioprine, rituximab. Additional option is cyclophosphamide in case, because all the three options are costlier. So if you see cost wise, so cyclophosphamide has still not been removed. It is still there because effectiveness was there, and is first line treatment short term glucocorticoids for duration of about 3 months, not more than 3 months to be done. If patient progresses on this therapy, then we move on to the next therapy, and that is add or switch therapy. You switch the first given drug to the these options, and the recommendation is against long-term glucocorticoids, and referral for lung transplant should be appropriate time for progressive disease should be done.
Thank you, Dr. Nitesh, for summarizing. And Amita Gunjal from Bihar, how do you monitor and manage potential side effects and treatment? We discussed. And Suraj Patwak from Kanpur, what are the ongoing challenges? We have discussed. And seronegative, this wonderful question. And Mihir, can you please answer, man? Okay. Seronegative rheumatoid arthritis presenting with ILD features. Please discuss about this topic.
So you're on mute.
Yeah.
Sorry, sir. So essentially, we have somebody who has an interstitial lung disease, and we are trying to identify what the cause for it is. So one would put it as an idiopathic interstitial pneumonia, but you have features which you have of a seronegative RA. So therapy would essentially go along the same line. There wouldn't be much of a difference as far as that is concerned. Correct me if I'm wrong, sir, but
No.
I would think therapy-wise, one would want to go about the same way.
Right. Thank you. And Dr. Deepak is asking, what are the criteria to increase MMF dose, and what are the side effects to look for? And Dr. Devi Jyoti, can you please answer?
so the common side effects are abdominal. So, and when we normally start at 500 mg dose and then increase to the optimum dose after the patient tolerates, and mostly patient tolerate in my experience, and we don't have major side effects.
I just to add whatever Doctor, I agree with Dr. Devi Jyoti, but what is the most important myth what pulmonologists have is, so they are really having some fear to initiate MMF at a full dose. My dear friends, if you are treating RAILD, please start the full dose. That is, if you are using mycophenolate mofetil, okay, 720 mg twice daily is the recommended dose, and then don't start at 320 mg and then start whether the response is there or not. So unless you give your full dose, the very rarely the response, the patient will not get stabilized. So that is the first important thing. Coming to side effects, so it can cause some amount of bone marrow issues, so monitor the CBPs. It can cause liver issues, so monitor liver enzymes. And then of course, if there is some amount of gastritis kind of thing, manage with PPIs. So that's what I look for. And Dr. Mihir, anything you want to add? Or anyone?
So they had conducted a study as far as it was a questionnaire as trying to find out how people tend to immunosuppress,
Right.
and often reaching those immunosuppression levels somehow has always been a problem. So 720 twice a day of MMF is certainly something that doesn't come naturally to a lot of the practicing doctors across the world. So not an Indian issue. And more importantly, starting slow is understandable because often these patients do have some GI symptoms and they don't tolerate MMF. So you can start off slow, but yes, you want to reach the correct dose eventually.
Right. So here is a question particularly for asking to Dr. Komal Shah. Okay. Role of site test in diagnosis of latent TB. What is this, Komal?
Sir, now the question is asked by my HOD. That's why it is particularly towards me.
Right.
So site TB test is like, sir, it is more like a Montoux test, but the antigen here used are ESET and CFP antigen. So what happens that it has convenience of Montoux, like it can be performed in the fields also. It can be given intradermal, but it has the efficacy of IGRA test. Means it will not be affected by BCG vaccination. So it is combination of both, and now it is in the program. So now we can use it for the NTP program also. So it is better than, I would say, better than IGRA and Montoux both.
Oh, fantastic. Thanks for that, new take home. So I would love to, yes, we have come to end, but Dr. Sayame again asked, Sir, Sham sir, can you please explain how can a multidisciplinary care improve outcomes of RA patients with ILD?
Oh, yes. I think from the start we have been saying that RA-ILD is not a single disease, but it's a multi-system disease. So when you say that you have a multi-system disease, it is but natural that you must involve a multidisciplinary specialist, and that involves both the diagnosis part, which is very, very important, with the pulmonologist, a radiologist, a pathologist, and a rheumatologist. And obviously, each one will have something to offer from his line of management, which would help the outcomes for these patients. For example, the pulmonologist would be very keen to give these patients incentive spirometry, breathing exercises, bronchodilators, investigate for obstructive airway disease, small airway disease, etc., air trapping, and so on. Whereas the rheumatologist would like to add something to relieve his part of the disease, and all these will together help the patient outcomes improve for patients with RA and ILD.
Thank you, sir. See, all the beautiful things comes to an end. But amazing thing is there are still 1800 plus participants who are listening to us. But if March 19th, 2025 webinar concludes without saying this news, it will be a great sin. So the thing is, today Modi, our beloved Prime Minister Modi ji, hailed astronauts for their grit, courage, and boundless human spirit for making it through and stranded at the International Space Station for 9+ months, and their journey to space, which was meant to last for 8 days, stretched to 286 days due to glitch in their Boeing spacecraft. And Modi ji has tweeted, "Welcome back, Crew 9. The Earth has missed you. This has been a test of grit, courage, and boundless human spirit. Sunita Williams and the Crew 9, and we are really proud of our Indian NRA Sunita Williams, have once again shown us the perseverance truly means. Their unwavering determination in the face of the vast unknown will forever inspire millions." So such a fantastic thing have coincidentally occurred today with our webinar, and sincerely thank CIPLA for their unconditional support for the academic events of ICS. We are proud to be associated with you, CIPLA and Harshal, and I must thank the for Nitesh particularly. There are huge number of applauses from the audience, Dr. Nitesh, for your slides. They are in demand today. So please do I request Harshal to share their email IDs to you. Please do share to them, because it will be a very wonderful PowerPoint in their library, in their desktops. And Sir Sham sir, amazing sir. We are truly, proud to participate and sit with you. I am honored to moderate you, such a senior and then wonderful pulmonologist. Thank you so much for allowing me to moderate, sir. Thank you, sir. And coming to Dr. Devi, fantastic inputs from you. Always, great things I learned from you. Thank you, Devi. Komal, again, fantastic to listen from you. And then the infectious, I have particularly restricted you to infection corner. My apologies for that. I will definitely in next webinar, I will exclude from infection component and then try to, pick up only pulmonology issues from you. But today, your presence was like icing on cake. It was badly needed because there are a lot of confusion areas. So I cannot go on discuss with everyone. So you have added really, rich experience of yours for the webinar. Mihir bhai, amazing. The lovely smile you carried all through. That is contagious. So brilliant inputs from you. Thank you so much. Over to Harshal. Harshal, you want to speak or you want me to close?
Yeah, I would like to thank you, Dr. Vijay, for moderating this so well. And I'd like to thank all the co-panelists for having been so good.
I sincerely thank all the delegates for active participation. By each name, I want to thank you because your participation in the webinar is a source of inspiration for all of us seniors to continue in the academic components. And we have crossed now 10:52 and still we are glued to any more questions are going to come. What a fantastic determination from entire ICS team. Thank you so much. Good night. Bye-bye.